for the talk on transplant outcomes in recipients recovered after COVID-19. May I invite the speaker, Dr. D.S. Rai. Now I'd like to invite the chairpersons for this session, Dr. Sri Bhushan Raju, Dr. Vivek Pathak, and Dr. Anil Kumar Beatty. Over to the chairpersons.
Dr. D.S. Ray needs no introduction to all the nephrologists of the country. He's a very eminent nephrologist from Calcutta, and he has done a lot of work in kidney transplantation and other. And I think he's got some CV which I didn't see here. Dr. Pathak, you have any CV you can read?
No.
No. Yeah. I think we'll start
he does not require any introduction.
Yes. Dr. Pathak will continue with that. So, Dr. D.S. Ray, please go ahead.
Thank you, Professor Raju. Thank you, people on chair and who are here in the group also. And good afternoon, ladies and gentlemen. I must thank the organizing committee as well as the scientific committee for inviting me. I'll start sharing my screen. Give me a second. I'll be speaking on transplant outcomes in recipients recovered after COVID-19. As we know, since the national lockdown started at 23rd of March of 2020, there was a suspension of transplant activities all over India. And from July, people started doing occasional transplantation. I believe by now, all of us or all the centers are doing their usual work of transplantation without any hindrance. What is the challenge in a kidney transplant patient who has recovered from COVID-19 is now we know a little bit after the experience, but it was the uncertainty regarding the safety of performing kidney transplantation in these patients, fear of adverse outcome of immunosuppressants in these patients, and we didn't know what is the optimal disease-free interval before, after the COVID-19 when you can do the transplant. There are no proper guideline. The initial guideline came from International Society of Lung and Heart Transplant. They advised for both donor and recipient to do SARS-CoV-2 by nasopharyngeal and oropharyngeal swab, sputum and tracheal aspirate, and especially for lung transplant patient bronchoalveolar lavage. They said the pre-transplant testing in recipient should be PCR based, and candidate, if it is PCR positive, should be deferred, should not be transplanted. And a patient who is getting a transplant done should be assessed clinically if there is COVID-like syndrome, even though there is no history of contact, even though the COVID-19 PCR results are negative, they should not be transplanted unless there is emergency, especially in lung transplant cases. Previous COVID-19 candidates should wait until clinical resolution of symptoms related to COVID-19 and 2 successive negative PCR-based tests at least 24 to 48 hours apart prior to transplantation if possible. For candidates who are found to have asymptomatic COVID-19, then 24 to 48 hours apart, 2 successive negative PCR tests after a period of 14 days since diagnosis is probably adequate enough to take them up for transplantation. For disease donor and recipients, they advised one should do the RT-PCR as well as the screening questionnaire related to COVID. If any of these is positive, either in the donor or in the recipient, they should not be taken up for transplantation. But in patients of lung transplantation, one can decide on case-to-case basis, depending on the situation, and informing the patients the negative effects of it. Then came American Society of Anesthesiologists. They actually advised for elective surgery. I believe kidney transplant, except in a disease donor situation, is mostly an elective transplant. So they divided according to the symptoms. If the patient had been asymptomatic or recovered from mild COVID, then a 4 weeks waiting period. If patient is symptomatic like cough and dyspnea, a 6 weeks waiting period. If patient has symptoms as well as is immunocompromised or diabetic or hospitalized, then one need to wait for 2 to 3 months, 8 to 10 weeks, and 3 months if the patient had been admitted to ICU with COVID. This seems to be little longer for our patients to wait. Waiting for 3 months, waiting for 2.5 months is little longer, and they may have problems waiting for that long if they have already the donor for transplantation. And the NATO later on came with the guideline with our members of ISOT, and they advised clinical and epidemiological as well as laboratory testing, clinical screening for fever, for respiratory symptoms, for anosmia, etc., COVID-like symptoms, epidemiological history of contact, history of travel, history of coming from a so-called red zone, all need to be taken into account. And COVID RT-PCR has to be done in both the donor and recipient as possible close to surgery, and within twice at least within 24 to 72 hours before the transplant. CT scan has been made mandatory for the lung transplantation, but on case-to-case basis for other organ transplantation. This is NOTO's futuristic specific guidelines where they have advised if there is a negative RT-PCR, negative IgG, go ahead and do the transplant. If there is a positive IgG, negative RT-PCR, they can be taken up. And of course, positive RT-PCR should not be taken up for transplantation. What will be the choice of induction agents? The International Society of Heart and Lung Transplantation doesn't advise any change of induction agent or even change of immunosuppression. One need to continue whatever protocol he is following. And I believe all of us are doing the similar thing. Post-COVID, of course, the management remains same as any transplant patient getting COVID. For mild disease, quarantine, stay at home, etc. For moderate to severe disease, one can withhold mycophenolate, mTOR inhibitors, or azathioprine. And of course, other treatment of COVID need to continue. The vaccination advice for COVID record patients remains same as it is for the other patients. If they can be vaccinated at least 2 weeks prior to transplant, they need to be vaccinated. If they have received one dose and transplant is happening, then one should wait post-transplant at least for a month if ATG and rituximab are not being used. If they are being used, they need to wait for 3 months for vaccination. I searched and I didn't get any large-scale study in literature. There were case reports of COVID recovered patients. All credit goes to Professor Vivek for organizing and getting data from 22 centers from India, and it is the largest study till now reported in the literature. 75 recipients recovered from COVID-19 from 22 centers of India. It's a retrospective cohort study. 23% of these patients had been asymptomatic, and around 68% had mild to moderate COVID, and 9% had severe COVID. They were taken up for transplantation with normal radiology to RT-PCR negativity and without any symptom of COVID for at least 4 weeks or more than 4 weeks. They were asked to maintain social distancing for 14 days. The outcomes were good. At 81 days, the recipient survival was 100%, graft survival was 100%, donor survival was also 100%. The biopsy proven rejection was only 6.6%, and that gives a boost to all of us to continue transplanting in the COVID era as well as COVID recovered patients. The statistics from our center, we have done in 73 patients till now who had been COVID positive and have recovered. We have transplanted them. COVID positive donor who have recovered and transplanted are 24, and 19 of these 73 and 24 are both donor recipient duo. We had only one death in around 9 months of mean observation time, and the death had been due to fungal pyelonephritis leading to graft nephrectomy and fungal sepsis in a patient who had severe COVID, recovered, had a CBA, had a ABOI transplant, and no, sorry, not ABOI, but he recovered and then had a transplant and died. All these 73 patients, majority, most of them were from 20 to 60 year of age. There are few above 60 and few below 20. And the comorbidities were diabetes in 33 and hypertension in 63. Most of them were transplanted after a month to two of recovering or of having COVID, 30 to 60 days post-COVID. Around 14% were transplanted after 2 to 3 months of COVID, and 17 patients after more than 3 months of COVID recovery, they were transplanted because of the associated problems. 48 of these patients had mild COVID, 15 had moderate, and 10 had very severe COVID, some of them needing ventilation. We use anti-thymocyte globulin in most of the patients, in 70 patients, and in 3 patients we used basiliximab. The intraoperative urine output was good in 69 out of 73%, in 95%. Immediate graft function was also there in 94.5%. Delayed graft function was seen in 3, and in 3 there was slow recovery of graft function. So average days from surgery to discharge was 11.5 days, and creatinine at discharge was 1.36. Some special cases, one patient who had severe COVID 9 months back went for second transplant, underwent that was a disease donor transplant, and he had delayed graft function. Biopsy showed pigment nephropathy, but successfully discharged with good urine output and a creatinine of 2.3, which later on dropped down to 1.3. We had 3 patients who had very severe lung involvement and high CT severity score from roughly around 21 to 21 by 25. They had been on antifibrotics. All had been discharged successfully after normal renal function post-transplant. 2 patients had turbulent post-transplant period requiring aggressive medical management. 4 patients we desensitized post-COVID for ABO incompatible transplant without any problem. All of them successfully transplanted and discharged with normal renal function. 2 patients post-COVID underwent second renal transplantation. One was discharged with a creatinine of 0.6. The other had DGF, and finally his creatinine at present is around 1.3 after around 7 months of transplantation. 2 patients who had severe COVID were re-intubated post-extubation for CO2 retention. They had earlier chest fibrosis, but we could take them off ventilation, and the graft function started functioning from the beginning, and they were extubated in a day or 2, and both had history of COVID, severe COVID and infection, as I said. This is a mother and son duo from Bangladesh. They came to us for transplant. We got the permission in March, but the lockdown came, so we couldn't do the transplant. We thought of doing the transplant in July, but both of them were found to be COVID positive. We waited for 4 weeks and did on 1st of August the transplantation. And to best of my belief, this is India's first donor recipient duo who were transplanted post-COVID and possibly worse. So the take-home message will be considering infection and death rate are high on dialysis. It is prudent to transplant deserving patients. There is probably no need to modify the immunosuppressant. One can safely use thymoglobulin as induction agent. The mortality does not increase in kidney allograft recipients in a shorter term. The COVID-related precautions, actually, I think I have discussed this with a lot of transplanting nephrologists, that the other bacterial infection have actually decreased because of the COVID-related precautions we took, isolating the caregivers, isolating the junior doctors, taking full care, not touching patients very frequently. I think this is something we have learned from COVID. We can continue post-COVID era when I don't know when we'll have post-COVID era, but we can continue, and this will give a reduction in the incidence of infection. Till now, all our patients, 73 patients who got transplanted, they didn't have second infection of COVID. Thank you for a patient hearing.
Over to the chairpersons.
Did you check the antibodies properly, and for how long these antibodies sustained? Any patient after starting immunosuppression, did you see a fall in the antibody
Can you
titers?
hear me?
Pardon?
Can you hear me now?
Yes, yes. Yeah,
Yeah.
Yes.
Actually, we have not tested antibody post-transplant, even pre-transplant. I think one should do that. We have not tested. But
We have done that.
okay.
What I observed is in those patients who have got natural infection following transplant, antibody positivity is around 60 to 70%. And those we have vaccinated, antibody production is around 30%. One more thing I observed in pre and post transplant with COVID is those people whose D dimer is high following COVID and remains elevated for some time, better to avoid transplant. It becomes normal because of thrombotic episode which may happen. I lost a post-transplant patient because of renal artery thrombosis also. So I look at the COVID panel blood test the first 2 weeks, and those patients who recovered from COVID, but the D dimer remains elevated, I postpone transplant till the time it becomes normal. Again, because of very of the thrombotic episode. And there are almost 10 or 12% patients in whom D dimer does not become normal even after 1 or 2 months. One longest which I have right now is 4 months, but it has become normal 4 months following transplant. So this is a word of caution for those patients. We are planning transplant following recovery from COVID, those patients on dialysis, that monitor those patients for elevated D dimer. Other parameters are not so problematic once the patient is recovered, but D dimer related to coagulation requiring anticoagulation, one should be careful. Anybody else comment?
I think as you saw our data, some of the patients took more than 3 months.
Yes.
To be transplanted. They are the patient who had either symptoms or had parameters, not only D dimer. We look for all the parameters, whatever COVID, immunological parameters, including CRP and all that. If it doesn't come down, we wait for some time.
Yeah, there are some patients who is totally asymptomatic, but D dimer is high. I will wait for transplant. I will not do that transplant.
I think yes. It's better to wait in those patients.
Any other comments? So far, we have transplanted many patients with pneumonia also with complete recovery, and we have not seen any post-transplant problems with those patients. And we have also used a full dose of thymoglobulin. Only thing, mortality in steroid-free transplants is much less.
Patak, any of your patients had a reinfection post-transplant?
Only one out of more than, I have kept the data of more than around 240 patients whom I managed with my old protocol with cocktail antibody, only one patient, that's all, no other reinfections. Overall mortality was 13%, but its steroid figure was 6.4.
Does the antibodies drop? Have you checked pre and post-op? Is there any change?
I have not serially monitored the antibodies, but as I was telling, I have monitored antibodies in all transplant patients by now whom we are vaccinating 1 month after the second dose. And natural vaccination really produces antibodies more than 70%, but our normal vaccination, natural infection produces. Normal vaccination, what we are doing, hardly 30 to 40% antibody.
Our experience, the vaccination takeoff is almost 90% with the Covishield. And only with Covaxin, it is much less. And of course, we don't have the post-operative. What we do is we take only if antibodies are positive right now. And of course, we safely wait for 3 months. And all transplants, as Ray said, including ABO incompatible or second transplants, all that we have been able to do. But we have not really monitored what happens subsequently to the antibody levels in these patients. Our experience is with natural infection, the antibody titers are extremely high as compared to the vaccine. Vaccine, the titer values are lower.
Yeah,
yes, but I'm talking about post-transplant, not pre-transplant.
Time span. I have seen in other patients, not these patients I presented, even with the infection, if you give a longer time span, so people who have been infected in the early part of COVID, last year COVID, their IgG levels have come down. So it is just a time span. Both for
related to time.
as well as the COVID infection. So maybe there will be a time where we can check IgG, try for a third vaccine.
Dr.
we are
Ray,
using-
did you have any incidents of cardiac events for those who had recovered from COVID? Because we had a 55-year-old
Yes.
diabetic.
I have got two patients with MI and stroke post-transplant with COVID. Presentation was
Yeah.
one was with stroke, other was COVID MI, acute coronary syndrome.
Definitely no, but we had a patient whom we transplanted pre-transplant post-COVID. He had a CDA.
We had a MI who died actually. That was the only mortality. Otherwise, majority did well.
No, I told you I got one renal artery thrombosis also post-transplant. He came with anuria. We did Doppler, no blood flow to the renal artery. He lost life also on ventilator. He had bad pneumonia also. His D-dimer was extremely high. So this persistently high D-dimer worries me. Even the patient is asymptomatic. I will not do transplant. Whether it's 3 months or 4 months.
Has the bacterial infection come down post-COVID era? Have you seen that in your transplant, like the normal pneumonias and other infections?
I think in the hospital, all department it is low. Pediatric department is closed virtually. Virtually closed.
We are running short of time. May I request the chairpersons to wind up the session?
So thank you all for attending the session. We had a lot of confusion last year how to deal with those patients who are recovering from COVID and dialysis. Now we know a little bit more and probably will know better next year. Thank you all for attending the meeting.
Thank you.
Anil.
Thank you, sir. Thank you, Ray. It was a wonderful presentation. Thank you, sir.
Thanks.
I thank the speaker and the chairpersons for their talk.